Dr. Namrata Sharma, and we thank her for her presence, but she's taken out time from a very busy schedule. So Dr. Namrata Sharma will be speaking to us about how to get the best out of my PGs, key pearls.
So thank you Tinku. I would be talking to you about how to get the best out of my PGs, and this could be in the form of all the skills that the postgraduates are supposed to acquire, such as clinical skills, surgical skills, research caliber, thesis, pursuit of publication, and adapting to technology. So I think clinical skills, one should be, like Tinku was also talking about, a logbook. All the postgraduates should maintain a logbook, whether it is for acquiring clinical skills or surgical skills, and generally they should be well versed at the end of residency with the training of these things which are shown. And this is the basic minimum, but there can be much more than this. All these examination techniques like slit lamp examination, direct ophthalmoscopy, tonometry, orthoptic, gonioscopy, stereo acuity, contact lens evaluation, etc. Timer. Apart from I think the clinical skills that are there, case presentations and ward round, I think play a very important role, because if there is a ward round, then it's like a bedside teaching, and I think that still holds true for now. We all in our postgraduates learned on ward rounds and bedside rounds. In the recent times, this is not the norm, but I think that is again the best form of teaching, and I think you learn most from your immediate seniors. So maybe your senior resident can teach you much more than what your consultant can teach you, because your hesitancy is not there and you can ask him or her anything. Then there should be teaching tools. Just to show example, that when you are seeing the patient on the slit lamp, actually if it is linked to a video or linked to a camera, then you can actually explain on the camera itself what the lesion is and what the pathology is. Of course, the student should know how to handle the key instruments and not be dependent on the optometrist to hold handle the instruments. Decent etiquettes and communication skills are very important. Conversing with the patient, making the patient comfortable. This is also part of teaching, and I think that the students, they learn inherently from their teachers. So you have to set a role model and example for them because they would imbibe the way you are dealing with the patient. Then simulators do play an important role, and it is said that you should not be jack of all trades, but I think at the level of the post-graduation you need to be jack of all trades to actually also choose later on what you want to master in. So these are just examples to show that it is important to learn surgery, but it is also important to learn the way we are going to diagnose by using the technology. Now, as far as the surgical skills are concerned, there are some surgeries which the postgraduate should be knowing how to do, and I think cataract surgery is very vital. Some surgeries which they may assist, they may actually not do, like retinal detachment surgery or keratoplasty. And some emergency surgeries where they should be able to do it, like repair of corneoscleral perf or corneal perf, because all emergency surgeries should be known by them. Then the surgeries can be learnt on, again, animal eyes or goat eyes, as is shown here, or on a surgical simulator if it is available. Nowadays, every conference has a wet lab. AIOCMT headquarters has a wet lab which we established 3 years ago, and also in various hospitals and in the various centers, the wet lab courses or the dry lab courses are being held. And this is a good tool before you actually start doing surgeries on the human eyes. But I think as a teacher, it's a different way of when you actually make them learn on the goat eyes or pig eyes. It's a different way of doing surgery, and sometimes you also have to relearn as to how to teach them on animal eyes. There are setups which are organized, such as seen here. This is the RP Center wet lab, where we do have a monitor, we can actually monitor not only by the side piece but also on the computer monitor to teach the student where he's going wrong and how it should be done. But I think one thing should be very clear, it is always very difficult to do surgery in animal eyes as compared to in human eyes, because their positioning, their handling and their stability is important, and that is completely different. This is teaching in surgical simulator, and I think VR surgery simulators, phaco simulators, there's a simulator by Help Me See on SICS. They are again good tools for getting the hand-eye coordination, getting the general reflexes of how to do a surgery. Then we do have in our OR or OT RP center, we have all the operating microscopes connected to the cameras, and so for us it is like doing live surgery every day, because when you are doing surgery there is a whole lot of the entire OT, your residents, the nursing staff, everybody watching you, so it's like doing live surgery daily for each and every case. For postgraduates, it is important that you make them assess the cases so that they can observe by learning. Even if the postgraduates edit the videos that you do surgeries on, I think it's a great learning tool or experience. I myself have learned phaco surgery editing other people's phaco videos, and when I did phaco surgery I didn't have a learning curve because I actually knew how to deal with whatever can go wrong. So coat size I think is something which is underutilized. You can do small incision cataract surgery such as this, then you can do phacoemulsification which is being shown here, then you can repair, make a perforation and then pretend to repair it by using 10-0 monofilament nylon sutures. Dr. Amar Pujari from our center has shown that you can even do squint surgeries using coat eyes if you have the whole globes. Even all kinds of surgeries actually can be done, like I said, live viewing again helps. This is just to show the RT view that we have, and it's a big screen and it's a 3D view, so the students, if they wear the 3D glasses, can actually see what is happening in a 3 dimension. So again, like I said, some of the surgeries you have to skillfully know before you finish your postgraduate. So I think as a teacher it is our duty to make them learn these surgeries by doing preferably, and if not by doing, then at least getting them to assist. Handling machines is a different ball game, but it is something that should be known. Sometimes these machines are available at your center, and so you can ask them to use it. At other times they may not be available, so please arrange in a nearby center where they are available so that at least they can go for a demonstration. Even the company people or the manufacturing people can get these machines for demonstration purposes to your center or hospital, and they do have demo pieces. Handling of these machines is important, but nowadays the technology has advanced so much that these are more handled by optometrists than by ophthalmologists, but nevertheless we should know the interpretation of these investigations. So again, the residents are expected to be familiar with this, at least keratometry, perimetry, pachymetry, FA, OCT, A-scan, biometry and corneal topography before they leave. As far as research is concerned, I think all of them are going to do thesis, and when you do give them thesis, you have to tell them the clinical relevance of the topic, devote time to the students for their thesis, analyze their documentation from time to time. Generally they have a tendency to come in the end and show you everything, but it is important that at least a quarterly audit or revision should be done. Otherwise, sometimes there are so many new things which you also can pick up and you've not thought of putting it as a parameter, and as the thesis go by, then these things can be done. And I think thesis is basically etiquette that has to be inculcated, because it goes through everything: statistical analysis, ethics committee approval, protocol writing, putting the references. So it it teaches the student as to how to commence research and do research. This thesis I put because this was the thesis which I did with my student Dr. Priyadarshini, and our publication in first go got accepted. Some of the thesis students are really very, very diligent. So this was our publication, and we didn't have to do any revisions also for that. Everything was done by her. Of course the surgeries were done by me, but record keeping, documentation, assisting in the surgeries, And as a result, when she did become a senior resident, her learning curve for all these surgeries was markedly shortened. And of course, I think it is our duty to help them to prepare for the exams also, whether it's a case presentation or it is a surgical. Some places like ours, they have to even demonstrate their surgical skills. So it is important for us to handhold them and to help them to prepare for the exam. And we have to teach the mentees, of course, other etiquettes to be, regular, to be very careful about their clinical findings, about the consents. And I think this is what we don't teach them, but we should. The financial skills, the medical ethics, the medico-legal matters, the communication skills, and last but not the least, stress management. So, the hand-holding or proactive learning is the way to go for the postgraduates, and we should do them as far as possible. These are the books which we actually wrote based on the feedback which was given by the postgraduates to us, because they wanted to do a reverse book where they wanted to know how the cases are managed rather than how the theory is given, and then the theory they have to, otherwise they have to mug it up. So the case presentations are given in these books, and what investigations to do, what surgeries, etc. are being taught to them. So thank you very much for your kind attention, and if there are any questions, I will be happy to take them.
Thanks a lot, madam, from someone who has been handled by you.
Thank you, Ellen.
And I want to comment on that last thing which you said, we are not teaching. This is what happened when I left our senior residency. I went to madam and complained I have not learned anything regarding private practice. You know what she did? One day she took me to the next speaker's clinic, left me for a day, and the next speaker, right from cleaning the floor, she taught me, Dr. Namrata Sharma. That's the, thank you.
Thank you, Ellen. Thank you.